So I'm Matthew Budoff. I'm a professor of medicine at the David Geffen School of Medicine and the director of cardiac CT here at Harbor-UCLA Medical Center in Torrance, and I've been a preventive cardiologist for about the last 20 years. We have a new test that we could use to better identify patients at risk. This is kind of a subclinical troponin measurement that shows risk but not infarction. I think that physicians should utilize this test for three reasons. I think first and foremost, it's the best predictor of future cardiovascular events. It's a simple blood test, but it's very, very predictive of future risk. I think two, it's actionable. We know that patients can be treated and their risk reduced by treating the patients appropriately based on the results of the test. And three, you can monitor over time. And we know there's a difference if you start low and go high with certain assays or start high and go low, that those have different implications. So having 2 points in time or multiple points in time allow us to monitor our patients and react to the problems that they may be experiencing. I think when we talk about the guidelines, and I was involved in writing the American College of Cardiology, American Heart Association guidelines for risk detection and how we should be screening patients, this test did not exist. Those guidelines were written in 2009, published in 2010, and we just didn't have enough studies on this test to consider it at that time. So I think that while it's nice to be included in the guidelines, I don't think it's a mandatory requirement for us to use a test. We have a lot of data now. We have a lot of clinical trials. We have a lot of long-term studies that demonstrate that the troponin I demonstrates increased risk. And I think we need to utilize those studies and incorporate the test into our practice. And the guidelines will incorporate the test, there's no doubt. When we revisit the guidelines, clearly we're going to be thinking about this type of test as an additional assay that we should be advocating for. But until that happens, we don't want to wait for the guidelines to catch up to clinical practice.